Usually when you open your medicine cabinet and just pop a pill for a headache, you assume the underlying science is just entirely settled.
Right, yeah. You have pain, you take the medicine, and the pain vanishes.
Exactly. We treat it like basic engineering,
Right.
like we just assume the researchers in the lab coats mapped out every single biochemical interaction that little tablet has inside your body.
It is a really comforting assumption. I mean, we look at a pill bottle and see this finished blueprint, just assuming pharmacology is a science of absolute certainties.
But then you look at the single most widely used medicine on Earth, a drug that is sitting in almost every home, an active ingredient in over 600 over-the-counter and prescription products.
Yeah, it's everywhere.
And it presents us with this mind-bending paradox, which is that scientists still do not completely understand how it works.
It's true. It is a genuine pharmacological mystery just hiding in plain sight, swallowed by millions of people every single day.
Welcome to the Deep Dive. Today, our mission is to unpack the pharmacology of acetaminophen. Or, depending on where you are in the world, you might know it as paracetamol, or chemically as EpiPen.
Right, exactly.
So we are pulling from a stack of medical history, biochemical research, and toxicology reports to really understand its biological mechanisms and its incredibly precarious safety profile.
Which is fascinating, by the way.
So to kick things off, let's just look at the standard textbook definition of this drug, because it highlights the core contradiction immediately. The textbook defines acetaminophen as a drug that relieves pain and reduces fever without significant anti-inflammatory effect.
Right.
Okay, let's unpack this. Because if it is aggressively treating my pain and my fever, why is it completely ignoring the inflammation?
Well, that missing anti-inflammatory effect is the exact anomaly that has frustrated pharmacologists for decades.
Decades, oh yeah. Historically, medical courses just lumped acetaminophen into the same exact category as aspirin and ibuprofen.
They called it a cyclooxygenase, or COX inhibitor,
Mm.
but that label implies it operates identically to those other NSAIDs, just with a weaker effect.
Which would mean it should at least do something for a swollen joint, right?
Mm-hmm.
Even if it's just a little bit.
Exactly. But the clinical reality is completely different. Acetaminophen has this bizarre split personality.
What do you mean by split personality?
Well, if you severely twist your ankle and the surrounding tissue swells up, taking acetaminophen to reduce that peripheral inflammation is basically a waste of time.
Wow, okay.
Yeah, it barely registers in the peripheral tissue. However, if you develop a severe fever or a pounding tension headache, it works beautifully.
So it's targeting specific areas.
Right. It crosses the blood-brain barrier into the central nervous system and just shuts down the pain centrally. So we are looking at this globally ubiquitous compound where this split personality still lacks a single, universally accepted mechanism of action.
That is wild. This drug is everywhere, yet it's essentially operating under an alias in our nervous system.
Pretty much, yeah.
But we actually got off on the wrong foot with this compound over a century ago, didn't we? The reason we are still untangling its mechanism today is deeply tied to how its discovery was completely botched in the 19th century.
Oh, the timeline of acetaminophen is a masterclass in how messy and nonlinear medical progress actually is.
So we start in 1878, right, at Johns Hopkins University.
Yes.
A chemist named Harmon Northrop Morse synthesizes the compound for the very first time. But he doesn't even test it on humans or animals. He just shelves it.
Right. It becomes what historians refer to as a laboratory curiosity.
Just sitting in a jar somewhere.
Exactly. It takes another decade for anyone to even consider using these types of chemicals as medicine.
Okay, so then what happens in the 1890s?
Well, in the 1880s and 1890s, European and American physicians were desperately looking for fever reducers. They started experimenting with coal tar derivatives.
Which sounds super safe.
I know, right? But they focused on two main contenders, acetanilide and phenacetin. And in 1893, a prominent physiologist named Joseph von Mering finally pulled acetaminophen off the shelf to test it in clinical trials.
To compare it directly against a phenacetin, right?
Exactly. He administers both drugs, and this is where the monumental error occurs.
Okay, lay it on me.
Von Mering observed his patients and reported that acetaminophen caused methemoglobinemia.
That is a mouthful. What is that?
It is a severe blood disorder where the hemoglobin in your red blood cells is oxidized. It essentially strips your blood of its ability to release oxygen to your body's tissues.
Oh, wow. So it's suffocating cells on a microscopic level.
Precisely. And based entirely on that single observation, von Mering declared phenacetin the safer, superior choice.
So phenacetin hum.
It did. Phenacetin dominated the global market for the next 60 years, and acetaminophen was completely abandoned.
It's like locking up the innocent bystander while promoting the actual thief. Because it wasn't until 1948 that two researchers at the U.S. National Institutes of Health, Bernard Brodie and Julius Axelrod, realized von Mering had the chemistry completely backward.
Right. They were investigating why that other early drug, acetanilide, was causing that exact same oxygen-depriving blood disorder in patients.
Okay.
So they approached the problem by mapping the drug's metabolic life cycle. And they discovered that when a human metabolizes acetanilide, the body breaks it into two distinct products.
And one of those was toxic.
Yes. One is aniline, which is a highly toxic industrial chemical. Aniline was the actual culprit, destroying the blood's oxygen capacity.
And the second product?
The second breakdown product was acetaminophen.
Okay, wait. So when von Mering tested acetaminophen decades earlier, he likely just had a contaminated batch tainted with aniline.
Exactly. And he blamed the innocent byproduct for the toxicity.
That is incredible. So Brodie and Axelrod's 1948 paper totally exonerated acetaminophen.
Yes, they proved it was the safe, active metabolite actually responsible for lowering the fever and relieving the pain, totally free from the oxygen-depriving side effects.
So then McNeil Laboratories eventually reads this research, and in 1955, they launch acetaminophen in the U.S. as Tylenol elixir for children, marketing it as this gentle, incredibly safe alternative to aspirin.
And here's the crazy part. Look at the fate of phenacetin, the drug von Mering crowned as the safe champion of the 1890s.
Oh, right. What happened to it?
Well, in the 1970s and 80s, global health agencies actually forced phenacetin off the market.
Why?
Because chronic use was directly causing analgesic nephropathy. It was physically destroying the filtering units in patients' kidneys and was heavily linked to urothelial cancer.
Oh, my God. So the drug trusted by the medical establishment for over half a century was literally a slow-acting poison.
Yeah. While the drug they discarded was the safe alternative all along.
Wow. Okay, so acetaminophen is finally vindicated and on the market. But that brings us right back to the biochemical mystery, because it safely treats a headache, but fails the sprained ankle.
Right, the split personality.
Here's where it gets really interesting. How does it physically accomplish that?
Well, we have to look at the cyclooxygenase enzymes, the COX enzymes. Whenever your body sustains tissue damage, COX enzymes act like chemical spark plugs.
Okay, spark plugs.
They ignite the production of prostaglandins, which are the signaling molecules that trigger inflammation, spike your body temperature, and sensitize your nerve endings to feel pain.
Okay, and typical NSAIDs, like ibuprofen, they just blanket inhibit those, right?
Exactly. They shut down those COX spark plugs everywhere in your knee, your stomach, your brain.
But acetaminophen clearly doesn't do that. So what is the mechanism?
In the late 1990s, researchers Dennis Ulya and Michael Percival helped formalize what's called the peroxide tone hypothesis.
Peroxide tone. Okay.
The theory argues that COX enzymes require a specific ambient level of peroxide in the surrounding cellular environment just to remain active. Acetaminophen is actually a relatively weak inhibitor. It can only overpower and block the COX enzyme when the local peroxide levels are really low.
Oh, wait, I need to challenge this. Because if the drug is just, circulating everywhere in my bloodstream, how does it physically fail at the ankle? It's the exact same molecule floating through the brain and the joint.
It comes down to competitive chemistry. When you sprain your ankle, your immune system rushes white blood cells to the injury to clear debris and start repairs, right?
Right.
Well, those immune cells generate a massive amount of peroxide as a defensive weapon. That localized flood of peroxide rapidly oxidizes the active site of the COX enzyme.
Oh, I see.
The chemical environment there is so volatile and oxidized that acetaminophen's weak molecular binding simply cannot hold on to the enzyme. The peroxide just kicks it right off.
But in the brain?
In your brain, the environment is highly regulated and very calm. The ambient peroxide tone is incredibly low, so acetaminophen can easily bind to the COX enzymes in your central nervous system and just turn off the pain and fever signals.
That is fascinating. The chemical environment entirely dictates the drug's effectiveness. That actually makes physical sense.
It does, but, researchers quickly realized shutting down COX in the brain wasn't even the whole story.
Wait, there's more.
Oh yeah, it only explained a fraction of the pain relief. The more contemporary and frankly more fascinating mechanism involves a metabolite called AM404.
AM404, what is that?
When acetaminophen enters your central nervous system, an enzyme called FAAH strips away an acetyl group from the molecule, chemically transforming it into p-aminophenol.
So the brain is literally altering the drug's structure.
Yes, and then the brain combines that p-aminophenol with arachidonic acid, which is a naturally occurring fatty acid in your central nervous system.
Oh.
When those two fuse, they create a completely new molecule, AM404. And animal studies have demonstrated that AM404 actively binds to your endocannabinoid system.
Wait, seriously?
Yes, specifically the CB1 receptors. It also heavily activates TRPV1 receptors, which are the exact same neuronal receptors that detect capsaicin.
Capsaicin, like the chemical that makes chili peppers burn.
Exactly.
So taking this standard, over-the-counter fever pill essentially forces your brain to synthesize a compound that taps into the exact same pain-dampening pathways as cannabis and chili peppers.
That is the leading biological model right now, yeah.
Yeah.
Activating those specific receptors hyperpolarizes the neurons. It physically makes it harder for the neuron to fire an electrical signal.
Like turning down a volume knob.
Exactly. It turns down the transmission of pain signals to your consciousness. It proves this is a highly complex, multi-pathway central nervous system mechanism, completely divorced from what ibuprofen does.
That is honestly mind-blowing. So the drug's journey into the brain provides this elegant, multi-layered relief. But the drug's journey back out of the body, specifically through the liver, that is an incredibly precarious metabolic tightrope walk.
Yeah, that's where things get dangerous. Once the drug has done its job, the liver has to clean it up.
Right.
The liver is the body's chemical processing plant, and its capacity has hard limits. When you take a standard dose, your liver attempts to dismantle the molecule so your kidneys can filter it out.
So what does this all mean for us? A good way I like to visualize this capacity issue is to picture the liver as a massive commercial kitchen.
I like that analogy.
So if a normal number of orders come in, the chefs process them safely and efficiently. But if, say, 500 orders drop at the exact same second, the kitchen gets overwhelmed, the fryers catch fire, and the whole system burns down. Essentially, you have two normal-sized doors and one danger door.
That is surprisingly accurate. The safe doors, the safe processing lines in this scenario, are the phase 2 liver pathways. Under normal conditions, about 50 to 55% of the acetaminophen is processed through glucuronidation.
Glucuronidation.
Right. The liver chemically attaches a large sugar molecule to the drug. Another 25 to 35% goes through sulfation, where the liver attaches a sulfate group.
Got it.
Both of these processes make the acetaminophen heavy and highly water-soluble, meaning it safely flushes out in your urine.
Okay, so that accounts for roughly 90% of the drug exiting perfectly safely through those two normal doors. But what happens to the remaining 10%?
Well, the remainder is shoved down a secondary processing line managed by the cytochrome P450 system. It heavily relies on an enzyme called CYP2E1.
The danger door.
Exactly. This pathway is dangerous. When CYP2E1 metabolizes acetaminophen, it converts it into a highly reactive, incredibly toxic byproduct called NAPQI.
NAPQI. Okay, so if the liver is generating a toxic byproduct every time I take the pill, why does my liver just shut down on a normal Tuesday?
Because your liver cells are stocked with a chemical sponge called glutathione. Glutathione is a potent antioxidant.
Oh, I've heard of that.
Yeah. The microscopic millisecond that NAPQI is generated, a glutathione molecule sacrifices itself, binds directly to the NAPQI, neutralizes its toxicity, and escorts it out of the body.
So the system works flawlessly until that chemical sponge runs dry.
Right.
And that glutathione reserve is not infinite, is it?
No, it really isn't. And that is the core mechanism of acetaminophen toxicity. If you take a massive dose, those safe sugar and sulfate processing lines reach maximum capacity. They physically cannot work any faster.
Right. The normal doors are jammed.
Exactly. So the liver is forced to shunt the massive overflow of the drug down that dangerous CYP2E1 pathway, generating just a tidal wave of NAPQI.
The kitchen is overwhelmed and the chefs run out of sponges.
Spot on. Once your liver's glutathione reserves drop below roughly 30% of their normal capacity, the free-floating NAPQI has nothing left to bind to.
So what does it attack?
It binds to the structural proteins of your liver cells, specifically targeting the mitochondria. It binds to the mitochondria, halts cellular respiration, and the cell just dies.
Which leads to a very specific pattern of organ failure.
Yes, it causes central lobular necrosis.
What does that look like?
Well, If you look at a liver lobule under a microscope, it's shaped like a hexagon, with blood flowing from the outer rim inward toward a central draining vein.
Okay.
By the time the blood reaches that central drain, it has been stripped of most of its oxygen. Now, CYP2E1 enzymes thrive in that low oxygen environment at the center.
Oh, no.
Yeah, so when the NAPQI tidal wave hits, the cells closest to the center vein are the first to be utterly destroyed. It creates a localized toxic ground zero that radiates outward.
Because safety completely hinges on that finite amount of glutathione, the margin for error is startlingly small. The standard maximum recommended adult dose is 4,000 milligrams per day. However, many clinicians and the FDA now advise capping routine use closer to 3,000 milligrams, simply to preserve a safety buffer for your glutathione.
It's a smart move. To put the acute danger in perspective, ingesting just 150 milligrams per kilogram of body weight is considered heavily hepatotoxic.
Which means what for a normal adult?
For an average adult, that translates to roughly 10 to 15 grams at once. In terms of sheer physical mass, it is a very small amount of medicine, but it basically guarantees acute liver failure without medical intervention.
This brings up a really critical point about how patients perceive this risk. I mean, wouldn't you know immediately if you took a toxic dose? Like, a common assumption is that if my liver cells are actively dying in a toxic wave, I would feel violently ill immediately.
You'd think so, but this poisoning is deceptively silent.
Silent.
Yes, that silent window is what makes it so lethal. During the first 24 hours after a toxic ingestion, the patient often exhibits minimal symptoms. They might feel mild nausea or a general sense of fatigue, easily mistaken for a minor bug.
So they assume they just need to sleep it off. Meanwhile, their mitochondria are actively collapsing.
Exactly. The physical structure of the liver is breaking down, but it takes time for the dead cells to burst open and spill their structural enzymes into the bloodstream.
And those are the enzymes doctors look for.
Yes. Those liver enzymes, which doctors use to measure organ damage, typically don't peak in the blood until 72 to 96 hours after ingestion. By the time the blood work looks catastrophic, irreversible necrosis is already deeply established.
Treating this is literally a race against a metabolic clock. If someone arrives at the emergency room, doctors utilize the Rumac mathenomogram, right?
Yeah.
Dated to 1975.
That's the one.
It is a mathematical graph that plots the concentration of acetaminophen in the patient's blood against the exact number of hours since ingestion. It basically predicts the trajectory of liver damage and dictates whether to deploy the antidote.
And the antidote is N-acetylcysteine, commonly referred to as NSAID.
Does NSAID just act as the synthetic substitute for the depleted glutathione?
Not exactly. It acts as the raw material. NAC is a precursor amino acid that your body desperately needs to synthesize new glutathione.
Ah, I see.
By flooding the system with NAC, you basically jumpstart the liver's ability to manufacture more chemical sponges, while the NAC itself also provides a secondary target for the NAPQI to bind to.
That's clever.
It is, but the timing is absolute. If administered within 8 to 10 hours of the overdose, NAC can prevent liver failure almost entirely. Every single hour delayed beyond that drastically reduces its ability to halt the necrosis.
Given this silent, time-sensitive danger, the sheer accessibility of acetaminophen creates a completely unique public health crisis. I mean, it is a leading cause of acute liver failure in the industrialized world, heavily driven by accidental overdoses.
Yes, and those accidents usually stem from the hidden stacking effect.
Because acetaminophen is utilized in over 600 distinct products, consumers frequently double or triple their dose without even realizing it. Just picture a normal sick day, You wake up congested and take a daytime cold medicine. That formula contains acetaminophen. By noon, your throat is killing you, so you take an over-the-counter painkiller. More acetaminophen.
Right.
That night, you take a sleep aid flu medicine. Even more acetaminophen. You have just unknowingly stacked your way past the glutathione threshold without ever exceeding the printed instructions on any individual bottle.
And that accidental stacking is a massive failure mode in public health. Regulators have had to alter packaging and policies to protect consumers from their own medicine cabinet.
Like what happened in the UK, right?
Yes, in 1998, the United Kingdom implemented strict pack size laws. This was based on research by a psychiatrist named Keith Houghton. They identified that the easy availability of massive bottles was facilitating impulsive self-poisoning.
Okay, so what did they do?
The UK mandated that pharmacies could only sell a maximum of 32 tablets per pack, and general retailers could only sell 16. Furthermore, the pills had to be in individual blister packs.
Oh, forcing the user to physically pop each pill out, interrupting the impulse. Did that physical barrier actually alter the toxicology data?
It really did. It resulted in sustained, measurable reductions in both acetaminophen-related fatalities and liver transplant registrations across the UK.
That's amazing. And the US FDA executed a similar targeted regulation in 2011, focusing on prescription opioid combinations.
Right.
They capped the amount of acetaminophen allowed in combo pills, like Vicodin or Percocet, to 325 milligrams per tablet. Patients were taking extra pills to chase the fading opioid high, and in the process, they were unknowingly destroying their livers with a massive payload of accompanying acetaminophen.
It was a necessary intervention, just to strip a lethal hepatotoxicity risk out of routine pain management.
We also have to mention the 1982 Chicago Tylenol crisis,
Yeah.
because it completely reshaped modern pharmacology.
Oh, absolutely.
7 people died after consuming extra-strength Tylenol capsules, laced with potassium cyanide. And to be explicitly clear, this had absolutely nothing to do with the drug's biological mechanism. It was a malicious act of product tampering by an unknown individual.
Right.
But that single event forced the industry to invent tamper-evident packaging. The foil seals beneath the caps and the heavy plastic blister packs you fight with today exist solely because of that crisis.
It revolutionized physical drug safety overnight. It created a visual guarantee that the chemistry inside the bottle hadn't been compromised before it reached your house.
Before we wrap up, our sources highlight 2 persistent misconceptions about how this drug interacts with the body. First, the NSAI myth. We explored the central nervous system mechanism, but it really bears repeating. Acetaminophen is not an NSAID.
Right. It does not inhibit COX enzymes in the peripheral tissues, and because it spares those peripheral enzymes, it does not strip the protective mucus lining from your stomach.
Which is huge.
Yeah, meaning it won't cause the severe gastrointestinal ulcers associated with heavy ibuprofen use. It also doesn't impair your blood platelets, meaning it won't thin your blood.
Which makes it the absolute first-line recommendation for pediatricians treating fevers in toddlers or for patients actively taking blood-thinning medications.
Exactly.
But the second misconception is the infamous rule. Never mix alcohol and Tylenol. What's fascinating here is that the actual biochemistry is incredibly nuanced.
It is. The public health warning is a blunt instrument, but the metabolic reality is a masterclass in competitive chemistry.
Okay, walk us through it.
Well, chronic heavy alcohol consumption is definitively dangerous. Chronic drinking actively upregulates or multiplies that dangerous CYP2E1 enzyme pathway in the liver.
So more danger doors are open.
Yes. Furthermore, chronic drinkers often suffer from malnutrition, meaning their baseline glutathione reserves are already depleted.
That's a bad combination.
It's terrible. If a chronic drinker takes a standard dose of acetaminophen, a massive amount of the drug is shoved down a hyperactive toxic pathway with very few chemical sponges available to catch the NAPQI.
But the metabolic math changes completely during a single acute binge.
Paradoxically, yes. If you consume a large amount of alcohol at the exact same time you ingest the pill, the alcohol actually competitively inhibits the CYP2E1 enzyme.
Wait.
The enzyme is so distracted metabolizing the alcohol that it temporarily pauses the conversion of acetaminophen into NAPQI.
So the alcohol and the drug are essentially fighting for the attention of the exact same enzyme.
Exactly.
Now, to be absolutely clear to you listening, this dynamic does not excuse mixing the two. The overall risk profile is still highly elevated. But it beautifully illustrates how this simple narrative of alcohol plus pill equals instant liver death completely misses the mechanical reality of how these metabolic pathways compete in real time.
It is a genuinely counterintuitive wrinkle that really proves how dynamic human metabolism is.
As we synthesize all of this, we're looking at a compound defined by a profound duality. Acetaminophen is simultaneously one of the safest pharmacological interventions available to human beings when metabolized correctly, and the leading cause of drug-induced acute liver failure in the industrialized world when it isn't.
The entire difference between a cured headache and a catastrophic medical emergency is dictated by a single biochemical bottleneck: the precise amount of glutathione your liver has left to spare at any given moment.
Understanding that mechanism completely changes how you interact with your own medicine cabinet. You are no longer just copping a pill. You are actively managing a highly delicate metabolic budget. You have to monitor the hidden stacking effect in your cold syrups, respect the dose ceiling, and understand that the drug is relying on your liver's finite resources to keep you safe.
And as you look at that ubiquitous little pill, consider this final thought. Because acetaminophen operates via these complex central pathways, engaging the endocannabinoid system and completely lacking peripheral anti-inflammatory effects, many modern pharmacologists are arguing it should be entirely stripped of its historical honorary NSAID title.
A completely new, retroactive classification.
Yeah. Despite being an active ingredient in hundreds of products and despite being metabolized by billions of human livers over the last 70 years, the most utilized medicine on Earth might soon be assigned an entirely unique drug class of its own, meaning the true identity of the drug in your cabinet is still actively being written.